Gentlemen, you are welcome to EAF Farms' launch of Caffeine Citrate in Ghana. Okay, so hello? Yes, we are back. Okay, so my name is Raymond Otu. I'm your host and I'm your moderator for the event. The first item on the bill is the welcome address. So as a host, I'm going to give you the welcome address. Then the rest of the program follows. So, ladies and gentlemen, you're welcome to Ghana. Those who are coming from abroad, those who are joining us online, you're welcome to EAF Farms Caffeine Citrate launch in Ghana. I might not introduce everybody, but I'm standing on all protocols and I'm observing them. So good evening. I'm the country representative of EAF Farm Ghana, and I want to specially say Akwaba to our foreigners, and all the Ghanaians know that Akwaba means welcome. So you are especially welcome to this event. It's a great pleasure and excitement that we gather here today to talk about the management of AOP and also the launch of EAF Farms' brand of caffeine citrate in Ghana. This event is perfectly timed and to coincide with the launch and the celebration of the World Prematurity Day. Now, on November 10th, EAF Farms sponsored and collaborated with PSG on the national launch of the World Prematurity Day celebration in Koforidua. And those who joined online and those who were there in person, we introduced our products there, and it was a very great event. Now, the theme for tonight's event is the power of caffeine citrate, supporting preterm infants from birth to a healthy future. I'm repeating that. The power of caffeine citrate, supporting preterm infants from birth to a healthy future. First and foremost, I would like to express my profound gratitude to each and everyone joining us once again, both in person and online, on this momentous occasion. Your presence here testifies your dedication and commitment in improving the health and well-being of our little heroes. Apnoea of prematurity is a severe condition that has devastating consequences, including death on premature infants. Now, research indicates that about 10 to 20% of premature infants are at risk of developing AOP. Now, notably, premature birth is a pressing public health challenge in Africa, with the World Health Organization reporting that 12% of all births in the region are preterm. The urgency of addressing this issue is underscored by the following alarming statistics. In 2022 alone, an estimated 1.7 million premature infants in Africa developed AOP, resulting in about 100,000 deaths, which is very, very alarming. And our facilitators tonight for this event are very experienced in the space of neonatology and pediatrics, and they are going to share valuable insights in the management of AOP. I entreat you to feel free, ask questions, contribute, network, and ensure the general success of this event. By launching caffeine citrate on Global Day of Prematurity, EAF Farms is sending a clear message about its commitments to improve the lives of premature infants in Ghana, and also to raise awareness of the importance of this issue. By this is merely a first step in EAF Farms' vision to provide a vital medication for premature infants through the African region for a healthy future. I want to thank you and once again welcome you to the launch of caffeine citrate in Ghana. Thank you very much. So we're going to share Farms, a brief introduction about Farms. So we're going to share our corporate video, which is just about 4 minutes. So stay tuned and enjoy the video. A round of applause. Hello? Yes. Okay, so at this point, we are going to invite our Senior Medical Director in the person of Dr. Barbara Lindberg to talk briefly about Farms.
And I promise it's going to be briefly. So my name is Barbara Lindberg, and the reason why we are here, you show the presentation already, 2 presentations, one you show twice. So we are a company, maybe I start and say something about myself. So you saw my strange title, which is medical marketing, because I started as a physician and then I joined pharma and I stayed there forever in different companies and in different countries. And I have to tell you that when I came to Ghana a couple of days, I was really touched by your hospitality and your smile everywhere. People are smiling everywhere to me, and it was really, really heartwarming, because this is not what you always get. Then the second thing which I was touched was the temperature. It's hot. It's hot. And I am married to a Finnish person, Finnish husband, when it's cold. Now it's snow. I just talked to my daughter, it's snow there. So these are these two discrepancies. Being here is also very emotional to me, because I have my personal history. My daughter, she was 30 years ago. I am from Poland. I was born there, and we didn't have surfactant. We didn't have caffeine citrate. So she died. And of course, it was a huge thing for me. I work it through. But today, when we visit your Dr. Amatorny, I'm very sorry. When we visit your ward, I was a little bit afraid how I'm going to react, but I actually feel my heart was very warmed because of the work which you are doing there and your devotion and how the things are running. And I am sure that this is the same which you are doing, all of you. So, and thank you. And about Etipharm, we are one of the companies, pharmaceutical companies. We are not the biggest, we are not the smallest, we are middle size. And this is the first year when we are actually in Ghana, and we are having Raymond, and we are having Valentina in Nigeria, and few other colleagues in other countries. We just want to be closer, because I had not a clue how it is in Africa, and I was one of these ignorant who was thinking that Africa is a country. It's not. There are many countries there, and there are huge differences, and I feel honored to be able to be here and to learn from you, so you'll see more of me. I not promise that I will learn your language. I don't know what he's talking in the car, but other than that, thank you very much for coming here. And if you are interested more in Etipharm, of course, we'll tell you, but let's focus on this, what is more important. Let's focus on the knowledge which we can get. So thank you very much, and I'm giving you the mic.
Thank you, Dr. Lindberg. Next on our program is the presentations. And as I always say, we are getting to the main meat of the event. If you are eating and you've not chewed meat, you are not done eating. So we are getting to the meat part of the event. And thus, we're going to get valuable insights from our resource persons and our facilitators, and we believe we'll go home rich in knowledge, motivated, and elevated to do great things in the field of neonatology. So our first presentation is from Professor Dr. Christian Poet, and he's from Germany, and he's from the University of Tübingen, and he is a lecturer in the university as well. So he's here to do a great presentation for us. So welcome him with a round of applause. Prof, you're going to so that you can change the screen there.
Right. Thank you for this kind introduction, and good afternoon, everybody. Admittedly, and I'm really embarrassed to say that, it's my first time in Africa. But I must say, it probably, hopefully, won't be my last time, because I really like the friendliness and openness of the people here. It's fascinating to see how things work in the NICU I saw today. It felt like home, and the same problems, unfortunately, also shortage of nurses. We don't have nurses, you don't have nurses. It shouldn't be like that, but in a way, it's very familiar. This is part of my hospital building. And the title you read there is different to what you read in the program, but never mind. I will focus on xanthines on a general level, and obviously with a strong focus on caffeine. And believe me, I say caffeine because I'm talking about caffeine because this is one of the few drugs I really believe in. I need a working remote control. I'm afraid it doesn't work with. Here we go. Okay, perhaps wrong direction, or it required Raymond to get this working. Anyway, so I'm not usually talking at company events, to be honest. I'm a clinician. I'm doing this because I really value these preterm infants and their families, and I couldn't give a talk on a product I can't stand behind. But caffeine is really one of these few exemptions where I really think this drug is helping a lot of babies because it has some very good effects. It's around for more than 40 years. And although it is one of the most used drugs you will see in a minute, up to 20 years ago, the total number of infants enrolled in any study in this field totaled 222. So the median number of infants per study was 13. You can't say anything about long-term effects with a study that had only 13 or 15 or 20 patients. You need much larger numbers. And then there were even concerns. There was one retrospective study from Australia, Peter Davis, and that showed that these infants had a higher rate of cerebral palsy who were treated with caffeine. Nowadays, we know this is because they had such a lot of apnea for which they received their caffeine that the apnea actually resulted in the cerebral palsy. It was not the treatment, but it was the problem for which the treatment was prescribed. We know that caffeine has a lot of effects. It stimulates the central nervous system. It is positive inotropic and chronotropic, so it lets your heart beat faster and contract more strongly. It dilates the pulmonary and systemic arteries and constricts the cerebral arteries so that it reduces cerebral blood flow. It increases chemoreceptor sensitivity. It increases your respiratory rate and your tidal volume. It increases your renal blood flow, so you pee more, or the baby pees more. If you have a strong coffee, we need to go to the loo. It increases gastric acid secretion, it increases metabolism and even clotting. So there are lots of effects, and in such a situation you need to do a proper randomized controlled trial. But as I said, that wasn't available until 2006, and this study collecting data until 2005, looking at the prescription of drugs in the US, caffeine, in terms of the frequency with which this was prescribed, ranked number 6 of all drugs listed. And at that time, there were a lot of infants receiving theophylline or aminophylline. And in the years leading up to this publication, the number of infants, or the proportion of infants receiving aminophylline or theophylline had decreased from 15% to 4%, while caffeine had increased from 10 to almost 17%. So there was a major shift. And perhaps if you are used to aminophylline and you want to compare it with caffeine, there's a meta-analysis having 3 studies and only 66 patients. But that showed very clearly you have far less side effects, 1/5 in numbers of side effects, no different in failure rates, and the serum level at which this side effect starts is much higher for caffeine. So you have a much broader or larger therapeutic window before you are getting into the zone where you have to be afraid of side effects. And this is another meta-analysis, this time is a cohort study of almost 80 infants. Again, comparing aminophylline with caffeine, it shows that the number of infants who had apnea recurrence during treatment was much smaller with caffeine than with aminophylline. the proportion of infants needing mechanical ventilation during this treatment was much more strongly reduced with caffeine, and the duration of additional oxygen and the level of oxygen given was also, the duration of oxygen was higher, but the level of oxygen needed was also higher with aminophylline. And another, now really a meta-analysis compared aminophylline with caffeine, now having 920 infants, so much larger database. And these are these so-called forest plots. So if you have this line is the identity. I need a pointer. If anybody has a pointer for me, that would be very helpful. Anyway, I try to write it through this slide without a pointer. Basically, it shows that caffeine is better in terms of effectiveness, feeding intolerance, tachycardia, and total adverse events. So it's really the better drug. And we have totally abandoned giving theophylline or aminophylline since 2005, so for a long time ago. And the main reason is you don't have to control the serum levels. You don't like to puncture the babies for taking blood, and the therapeutic width is so large that you don't need to do it. And the other thing is the quality of the information from randomized controlled trials is so much better. And this is due to this very large study published in 2006 and 2007, the first publications from that study, done by Barbara Schmidt from Canada at that time. She randomized 2004 infants between 500 and 1250 grams at risk of apnea to either caffeine or placebo. And the primary outcome was whether that increases the risk of death or neurosensory disability at a corrected age of 18 months. And I can tell you, our nurses, I was a newly appointed professor at Tübingen in the south of Germany, and we wanted to participate in that study, and our nurses went berserk. They said, you can't give a placebo because we believe in placebo, in caffeine. So by this study, where half the babies were receiving placebo instead of caffeine, they were very much against it. So basically, we had to get out of this study because our nurses didn't like it. But I'm lucky that other centers hadn't this headwind and completed the study. And as already said, the criteria were baby being a candidate for caffeine and having no major malformations. And this was the loading dose, 20 milligrams caffeine citrate per kilo and between 5 and 10 milligrams per kilo per day maintenance dose. And again, no serum levels, not necessary. And the primary outcome was death or cerebral palsy or MDI below 85% of the Bailey scale. And you can read the long list of secondary outcomes yourself. And particularly also clinically long-term meaningful outcomes like PDA, patent ductus needing ligation, BPD, bronchopulmonary dysplasia at 36 weeks gestation, severe retinopathy of prematurity. So they are really important long-term outcomes. And to address these long-term outcomes, you need a large sample size. So Barbara enrolled 2,006 infants, randomized to caffeine and placebo. They had only a small rate of incomplete or missing data, only around 7%. And here are some clinical data. So the groups are very comparable. Birth weight was around 950 grams. Gestation age around 27 weeks. Around half were girls. And antenatal steroid use was high, which is good. And this was a primary outcome. 40% of infants in the caffeine group either died or had the impairment at 18 months corrected age, and this compares to 46% in the placebo group. So that yields an odds ratio of 0.77 with this confidence interval, which was highly significant. So the primary outcome was improvement in death or disability at 18 months corrected age. But if you look at some secondary outcomes, it's also very important to remember that. the risk of cerebral palsy was almost halved. An odds ratio of 0.58 means the risk is 58% compared to the placebo group. A mental development index of less than 85 was also significantly reduced. Deafness or blindness was too rare, but there were no trends at all, but not significant differences. And here are the important secondary outcomes alluded to earlier. The rate of BPD was reduced by 40%, the risk of PDA reduced by 30%, the rate of PDA ligation, surgical ligation, was reduced by 70%, and retinopathy requiring treatment was also reduced by 40%. And all of these outcomes, or these differences, were highly statistically significant. So it is really a very effective drug addressing a lot of important clinical outcomes. Now, with such a big trial, there were obviously then some secondary analyses. One was, for example, that they looked at the primary outcome in dependence on which form of respiratory support the baby was at the time of randomization. And that showed that the effect on primary outcome was particularly true if the baby was on CPAP or on mechanical ventilation at the time of randomization. And also the difference in duration of mechanical ventilation was important if you started early. If the caffeine was started at less than 4 days, it was reduced by more than 1 week, whereas if you started after day 4, it had no effect on mechanical ventilation anymore. So you need to give it early. That's the conclusion from this data. And then there was also a dose-dependent effect. The primary outcome, death or impairment, was non-significantly reduced if the babies received a dose of less than 7 milligrams per kilo per day of caffeine citrate, whereas it was highly significant if the dose was larger than 7 milligrams per kilo per day. And you also had to give it long enough. The effect on cerebral palsy was only significant in infants who received it for at least 45 days. So just giving it for a few days won't affect this very important outcome of cerebral palsy. You have to give it at least 45 days. That means at least 6 weeks, 6.5 weeks. And then Barbara luckily got money to do follow-up studies, which I think is very important. Not only the 2-year or 18-month follow-up, already published in 2007, but also the 5-year follow-up, where she still could collect around 833 children in the caffeine group and 807 in the placebo group. And again, there was still, at 5 years, a significant improvement in motor impairment. And even at 11 years, there was still a significant, hugely significant difference in the risk of motor impairment. So in my view, caffeine is the only drug where we have really data into middle or end of childhood, and we still see a beneficial effect. I don't know any study, any drug we give to our patients where you can have an effect visible 11 years later. And it's no surprise that the WHO listed caffeine amongst its list of essential medications. As part of the CAP study, which was done in America, Australia, and 2 European centers, the Australian colleagues did lung function when these children had reached age 11 years. And they found that the lung function, even 11 years after premature birth, was significantly better in infants having received caffeine than placebo. So not only you could detect a better neurological function, but also a better respiratory function in these babies having received caffeine compared to placebo. Now you may think, okay, if this is such a great drug, why not giving more of it in babies who don't respond nicely? And this question was asked by this Australian group. They used a loading dose that was 4 times the dose normally used. And now I have to switch from caffeine citrate to caffeine base, which is only half what you have caffeine citrate. So 20 milligrams of caffeine citrate corresponds to 10 milligrams of caffeine base. And with this much higher loading dose and this also higher maintenance dose, they had indeed more babies extubated by 48 hours. They had a trend towards less BPD, and they had no neurological differences. However, the Americans tried to repeat that study to know whether this would be our new standard dose in babies not responding to low-dose caffeine. But that study was stopped after some 68 babies because they had suddenly seen that more than 1/3 of the babies had cerebellar hemorrhage. So a bleeding in your cerebellum is a bad thing to have for a baby. So they stopped the study, and the conclusion for us, knowing these data, is never use caffeine at that high dose. You may increase it by 1 milligram per day per kilo, but certainly not double the dose to what you are used to. And this is a study I saw at a conference in the States. They looked at the effect on intermittent hypoxemia. I have always been interested in hypoxemia. In theory, you can stop breathing as long as you like. The thing that matters to your baby is whether the baby develops hypoxemia, lack of oxygen. And they showed quite clearly in this nice study that the higher the dose, also the less intermittent hypoxia these babies have. But mind you, this should not be repeated these days, knowing now that there's a risk of cerebellar hemorrhage. But as a proof of principle, it was an interesting exercise, I think. And the other question, and that may also be important for your setting here in Africa, that caffeine still works if the baby is more mature. So even if you have a 34-week infant or a 35-week infant studied in this study from the United States, you can see that the proportion of time spent below 90% or below 80% oxygen saturation is higher than with placebo. So it's not only helpful to the more immature babies, it is still helpful to the more mature babies, the so-called late preterm infant. Sorry, the study I have already shown. Now, I mentioned earlier that caffeine also has the advantage of that you don't need to check plasma levels. And this is why I may say that, because in this study with 231 plasma levels determined in more than 100 babies, they showed that plasma level was really above the safe range in only 3% of infants. And that was not more likely in infants with impaired renal function or impaired liver function. So basically the conclusion from that large study was you don't need to check plasma levels routinely. And the way we do it in my center in Tübingen is we only measure plasma levels if we are unhappy with the effect. So then we want to see, can we give a little bit more if the plasma level is low? Or the other question is, if the baby has tachycardia, we want to know, is this due to caffeine or is this due to other reasons? So only for specific indications, we do monitor blood levels, but not routinely, not necessary. What you need to keep in mind is it has a very long half-life. So it takes days until it is washed out of the body. In these earlier studies, it took between 50 and 100 hours. And these more recent studies, they are more uniform. The half-life is between 100 and 144 hours. So if you translate that into days, even after 4 or 5 days, you still have half your serum levels in your blood after stopping treatment. So it really takes a long time. Now, should we start caffeine earlier? I think I said that earlier. This is a good idea. And this is also based on this meta-analysis, which showed that if you give it within the first 2 days, you have a better effect on BPD, on IVH, or on PDA. And this is also important to keep in mind. What I teach to my junior staff these days is forget about caffeine as an apnea therapeutic. Use caffeine as a protective measure for your baby's lungs and brain. And if you rethink that you don't have to wait until the baby really develops apnea, you start your caffeine to protect the lung immediately after birth. And that's what we are doing. We give caffeine already in the delivery unit in these immature babies. And that's a change in philosophy, but based on the fact that this is not a drug to just prevent apnea, which it also does, fair enough, but also to save the baby's lungs. Now, an important question clinically is, when do you stop caffeine? And also, when do you increase the dose or use other measures? And here we have developed this apnea score, published in Acta Pediatrica many years ago, and which we still use in our unit. So we assign a certain value to each event happening, and we make the severity of the score dependent on the nurse's intervention. And if the nurse thinks that the baby needs some stimulation, we get 2 points. If the nurse thinks, the baby will soon need bagging, we give 3 points. And if the baby needs to be bagged with a positive pressure ventilation, we give 8 points. And we add up these points, and if the score exceeds 20 in 8 hours, we increase the caffeine dose, or we increase what we do against apnea. And in the more mature infants who are less tolerant to intermittent hypoxia, we already increase the dose if you have more than 10 events per 8 hours, per shift, basically. So this is not evidence-based. I need to stress that. This is personal practice. But I know many centers in Germany who have copied it and think it's much better because it's giving a more objective picture to your charts what the baby is experiencing. So when do we stop caffeine? In the CAP trial I mentioned earlier by Barbara Schmidt, they stopped at a mean age of 34.4 weeks. And you need to keep in mind that we published many years ago, when I was working in the UK, we published a study, what is normal, and this was a study on 160 babies who were sent home at a mean gestational age of 36 weeks gestation, and the 90th percentile for intermittent hypoxia to less than 80% was still at 8 or 10 events per 12 hours. So intermittent hypoxia of short duration is common in these babies, and they can go home with it. They should not have events where you need to stimulate the baby, which last longer. And here, a survey amongst US neonatologists came to the result that they required at least 5 event-free days. In our own practice, we require only 4 event-free days. But whether that's good or bad, I can't tell you. It's just an approach with which we cope very well. We hardly ever have readmissions for apnea, so it seems to work. Now, I'm in Africa, and I found this publication, which is pretty recent, and it struck me that it is extremely variable how much you have to pay. I'm not sure how much your company will charge for it, what your daily prices will bill, maybe higher. But look how much you have to pay if you live in Nigeria. How that is justified, I can't tell you. I found it surprising that there are huge differences even within neighboring countries. So I come to the end of my presentation. I try to convince you that caffeine is extremely well studied in small preterm infants. And we know that it still has beneficial effects you can note 11 years after having given the drug. It is the only drug ever to reduce the risk of cerebral palsy, which I think is also very important. And it reduces the duration of mechanical ventilation, particularly if started early, reduces the risk of BPD, severe retinopathy, and duct ligation. You don't need to check serum levels unless the infant shows side effects. And given this all together, I'm quite glad that now caffeine is officially licensed also on this continent, because it is really a helpful drug. Thank you for your attention. And perhaps let me stress that, because I really don't do these company talks normally. This is what I'm saying here, I would tell any other audience, and without any company involvement. This is really what I believe is true. Thank you.
Thank you very much, Prof. So normally we would take a break and ask questions, but what we want to do this time around is we want to let the second presentation go on. After that, then we will leave room for questions and answers so that it will be a broad discussion after the second presentation. So, Prof, I think you can take your seat. Thank you very much. So, next on the program is a doctor that, as soon as I joined EAF Farm, he's one of the doctors. You know, when I started going to the NICU, he's one of the first doctors I met. And as soon as I said, I have caffeine citrate, he jumped at it because he knows the benefit of caffeine. He's Dr. Kwabna Onwuna Ajiman. He's a neonatologist from the Greater Accra Regional Hospital. He is the next presenter for us this evening. Doc, you're welcome.
I think we are going to drink some coffee. And why isn't it morning cups? Okay, right. Thank you so much, EAF Farm, right? And inviting us to share our experience on apnea of prematurity. Our hospital is just a couple of streets from here. In Ghana and in most sub-Saharan African countries, we are very much aware that the under 5 mortality rate is really dropping. It's dropping at a very fast rate. But unfortunately, the neonatal component, that is the neonatal mortality rate component of that under 5 mortality, is rather plateauing. It's not dropping as we would love to. And it's mainly because probably the neonatal area, it is labor intensive and it's capital intensive. You cannot, it will expose you if your health infrastructure is poor. What is driving this neonatal mortality rate is only 3 things: preterm birth complications, sepsis, and intrapartum related asphyxia. These are the 3 things that are killing our babies. And unfortunately for us, preterm birth anywhere in the world is increasing. In Ghana, we are seeing it's, and then you, the young ones coming up looking after newborn babies, the task ahead is huge. You need to up your skills to be able to save these babies. And gradually, we're moving from the concept of just saving these babies to disability-free survival. It's not just to say we're saving the baby, but what happens 2 years, 18 years from what you've done. And if you live in a country like ours where having a child with special needs is a huge task. It's cost. So we need to be very careful. So I term it as a central health priority. We need to make it very, very crucial to save these babies very well. What is happening now is that we now know very well that these babies, apnea of prematurity is crucial to us. All of you who work with the NICUs, you know how it feels like these babies ceasing breathing. The definition is clear. It's cessation of breathing for more than 20 seconds, or if it's less, that is accompanied by bradycardias and desaturations. You have to run to save that baby. It's scary. And it is one of the leading causes of respiratory failure in our NICUs. And if you're failing your breath, it means you need mechanical ventilation. And if you work with us in a country where we don't have mechanical ventilation, it means that these babies are going to die. Now, with people with mechanical ventilation, are even running away from mechanical ventilation because it traumatizes these babies. It's not physiological, right? So we know very well that mechanical ventilation really destroys the lungs and is the leading cause of chronic lung disease for these babies. So even in the best of centers, they are all shifting to less invasive ventilation, that is the CPAP. But you need a baby to have a very good respiratory drive to be able to use that CPAP. Other than that, they will fail the CPAP. Now the question is, so most centers, most international organizations are now recommending pharmacological way of treating apnea of prematurity, right? And we've been using this caffeine way before most of you were born, right? It's an old drug, different drugs. But currently, caffeine is the choice among the pharmacological agents. Why? Because it has a very good therapeutic window. It means we can play around the doses, and then side effects are very minimal. It has a very long half-life. It's about 96 hours to 100 hours. It's very long. Another beautiful thing about it is that studies have shown that you don't need therapeutic levels, right? So it's good for us. And I think the fourth crucial one is the cost effectiveness of caffeine compared to the other drugs. So caffeine has really emerged as the pharmacological drug of choice to treat apnea of prematurity. So in most countries, it's there. What about us? How has caffeine infiltrated Ghana? So we decided to have a little, we decided to have a very quick survey when I heard that we're going to give this talk. We decided to speak to pediatricians and neonatal experts throughout the country, in all our regional hospitals and the tertiary hospitals, right, to look at what is, on assumption that if whatever they say represents the protocol in their units. So we wanted to see how caffeine is doing in Ghana. So we set up a few questions. And I think I would like to use the opportunity to thank all the doctors who responded to this survey. We are very, very grateful. So the first question we asked was, do you use caffeine in your unit? And I'm happy to say that all the units, in at least all the regional hospitals and tertiary institutions in Ghana, caffeine is there. The second question was, do you use aminophylline in your unit? And 50% says yes, we still use aminophylline. So aminophylline is still, it's an old drug, it's still, we are using it. And it has very narrow therapeutic window, so toxicity is very, very amazing, right? And it has a lot of side effects, but we are still using it in 2023. The next question we ask is, what do you use the caffeine for, right? And all of them said they use it for prevention of apnea of prematurity. 80% said they use it for the treatment of apnea of prematurity, and only 20% use it as, to prevent extubation failure. It's very low here because most centers in Ghana don't intubate. So probably that's the reason why that area is very low. The next question we're interested is, when do you initiate caffeine? From Prof's talk, you could clearly see that this indication is so crucial. And most studies have divided into two: early caffeine, that is less than 3 days, and then after 3 days is late caffeine, right? So in Ghana, I was so impressed to see that if we're going to use caffeine, most of our regional hospitals and tertiary hospitals will use it less than 72 hours. And studies have shown the benefit of early caffeine. And 10% will use it after 72 hours. The next question we're interested in, what gestational age do you routinely use caffeine? And 11%, majority will use it up to 34 weeks. So it's quite impressive. But some will say they will go as high as 35 weeks. And these are things, if you survey the whole Africa, I'll show you, in most countries in the world, there's so much variation in caffeine usage. So this is not new. We just want to see our own variations. And then we looked at what corrected gestational age do you routinely discontinue? It's like intubation. When to intubate is not a problem, but when to extubate. When to start caffeine is not a big deal, but as to when to stop is so crucial, variations. So 40% say they will stop at 34 weeks. 10% say they will stop at 35 weeks. and 50% say they will stop between 36 and 40 weeks. And this is fair because you have to take every baby as an individual. And we are beginning to see that things like caffeine, maybe one size may never fit all. So you have to evaluate every baby on its own merits and demerits. Then we looked at the formulation. What do you have in your unit? All the hospitals have oral caffeine, and only 40% said they have IV caffeine. And I think today's lunch, they will be interested in this question, that only 40% of our hospitals, tertiary regional hospitals, have IV caffeine. And another question, what loading dose do you use? If you are to start caffeine, we always will load. What loading dose? 77% said they will load with 20 milligram per kilo. This is caffeine citrate. This is not caffeine citrate. And 11% will say 8 milligram per kilo. And another group said 4.5. This question was, what is your... So all the regional hospitals gave me only 3 values, and majority quoted 20. Some said 8 and 4.5. So you see the variations. We are using it, but there's a huge variation in our practices. And it came to the maintenance. If you are to continue, what maintenance dose will you use? And I think majority kept to the 5 milligram per kilo per day. And then 22% almost said 10 milligram per kilo per day. And then 11% said 3 milligram per kilo. So loading dose, there's a huge variation. Maintenance dose, there's a huge variation in our practice. So I am, based on evidence, we're going to present our protocol probably at Ridge. And I know there will be a lot of questions after this, right? And so this is it. So we will definitely three main indications. And then the question of early versus late. And we can never talk about caffeine without talking about the CAP trial, the caffeine for apnea of prematurity. I think it was the biggest multi-center trial ever. That helped us to answer major questions as to the safety of caffeine. But when I was doing the research, I realized that they used an old study that used the 20 milligram per kilo, right? And then they also used 72 hours and more than 72 hours. So they used the 20 milligram, and they realized that the babies they started early. The number of days they spent on the respiratory support was less, and it was quite significant. And crucially, the babies they started less than 72 hours, the BBT rate was quite very low. So we also try as much as possible to start our caffeine within the first 72 hours after delivery. And this is a study that also did show that when you start early, you may get very good results with early caffeine. But the research was quite very conflicting, right? There was another study that looked at CPAP failure rate, and they concluded that you give it early or you don't give it early, your CPAP failure rate is the same. And the authors here were quite convinced that probably the mechanism of BPD and that of CPAP failure are two different things altogether, right? So this should not, we should not use this study to say that we're not going to give it early. So we still, in our unit, will try and give caffeine within the first 72 hours of life. And another crucial question is to high dosage versus low dosage caffeine. And if you do such, you realize that a lot of studies, people are using very high doses, and high doses reflects good outcomes, especially with the BPD and other things, but side effects increases, the cerebral hemorrhages and other stuff. And again, we will resort to the CAP trial where they use 20 milligram per kilo loading dose, and after 24 hours, you start your maintenance dose of 5 milligram per kilo. And we want to stay safe, especially us who cannot measure caffeine levels, right? So we want to stay safe. So in our unit, we still stick to the 20 milligram per kilo start and 5 milligram per kilo daily. And I want to chip in this, that if you are on your unit and a baby, you struggle with apnea of prematurity, before you alter your dosage, sit back, reflect, and rule out these things. This is something we see in our unit a lot, hypothermia. This is a typical 30-weeker who has landed at KMC, and instead of mommy putting in the KP position, they are always lying on the bed, they feel cold, and apnea restarts, right? So we see this a lot in our units. So make sure baby is not hypothermic. Hypoglycemia is also another crucial thing. Anywhere you see hypothermia, hypoglycemia, you search for sepsis. It's crucial. PDA. I know most units will not have an echo, but we entreat you to have your clinical skills. You don't need an echo to diagnose that PDA. Any baby with apnea, typically 29, 30 weeker, who is lying there, you come to the ward, look septic. Not all septic looking babies are septic. Just take time, feel the pulse, listen to the heart. You are there, right? And then all you need to optimize the treatment for your PDA, and you may not need to increase your caffeine dosage, right? Electrolyte imbalances. If you do electrolytes, a lot of our babies, typically a 29-weeker, 30-weeker who is corrected age at 31 weeks, a lot of them, they lose potassium. Hypokalemia is very common among them. If you don't treat that hypokalemia, your apnea won't go away. If you don't treat that hyponatremia, that apnea won't go away. So please, hypocalcemia. A lot of our babies are very hypocalcemic. All our sick babies, they are hypocalcemic. You've got to treat. Other than that, you keep increasing your dosage of your caffeine, and you may end up getting toxicities. Anemia is a hot topic. When to transfuse, right? You get your preemie who is doing well, and all of a sudden starts getting apneic attack. You draw blood, HB sits at 7. transfuse, not to transfuse? And nobody can answer that question. So you just take a decision and go ahead, right? So we have those who are very liberal, slightly they are transfusing, and there are those of us who are very conservative. We will want it to drop. But if you have an apneic attack in a pale baby, probably optimizing the oxygen carrying capacity will be the way to go, right? So search for anemia and deal with it. Reflux. I have a baby currently on my unit. Anytime they feed, after feeding, you see baby desaturating, and you see milk in the mouth. It happens a lot. If you don't address that reflux, you will keep on increasing your dose of your caffeine, and that it's not good clinical practice. So please, before you increase your dose, please make sure. This is not exhaustive. There are others, but in Ghana, this is what we see. Make sure you run through this so that you solve it, and then you keep your maintenance caffeine intact. When do you stop caffeine? When you start caffeine? We routinely around 32, 34 weeks, and if baby has stayed apneic free, if you read most books, they will tell you 5 to 7 days. Number one, we don't have space on our unit. You've got to go home. So we keep to 3 days. If you've been apneic free for 3 days and you are around this age, we may stop and monitor for 3 more days. If you are good, you go home. Most centers will say observe for 7 days, and it's a major problem for us because we don't have space. So we will discharge them a bit earlier. Observe for 3 days and risk. Probably life without risk is not interesting. But then the babies who are very extreme, we realize that, then 700 grandma and then 900 grandma, they may will continue on the caffeine for a longer time. So that's why I say, drawing protocols for this, you always have to make rooms. Every baby is so different. And if that baby corrected gestational age is 34 but still gets apneic attacks, that will not be the best time to stop the caffeine because I'm 34 weaker. So please, let's make sure that we address these cases individually. And we now know very well that caffeine for us is very, very effective. It is effective, but it's not without side effects. I have never seen a drug without side effects, so definitely there are side effects. The question is, how do we get the best out of the caffeine? We get the best benefit with minimum side effects as much as possible. So we need to play it safe. But to answer these questions, we need local research to be able to answer these questions. If you see all of the the research I've quoted, they are all not within us. It's all outside the continent. So we need the local base to help do more randomized control trials to solve this problem, to answer some of the questions for us within our population, right? And I was so happy to see the African Neonatal Association. This year we just completed a massive survey in Africa, asking all neonatologists and pediatricians, all countries in Africa. Our main objective was to look at the views, whether you have caffeine or you have aminophylline. And the second crucial question is, how do we approach in terms of research? As you said, we know caffeine works. How are you going to randomize caffeine with a placebo is going to be a major problem. So we are thinking through. This is at the manuscript level. Probably later next year, results will come, and then I hope they move so that we'll be able to do more multi-center trials in Africa for us to be able to know how best caffeine will help us. I strongly believe we need the caffeine more than, because one of the latest information about caffeine and the pro-inflammatory activity of caffeine, and a lot of our babies are very septic. So probably we may need the caffeine more than other countries, right? So we're cautiously awaiting this trial, this survey, and it's going to be interesting. I will end here and I will go back to questions. Thank you very much.
Thank you, Doc. We also entreat our online viewers. If you have any question, you can type it in. We are going to project your question, and it will be answered. So we are still awaiting your question. Any question? Okay.
Yeah. Thanks for the presentations. My name is Tony. I'm a pharmacist. The little observation I've made is that normally when prescriptions come for caffeine, you need to go back and ask the prescriber that what she or he's written, it's the base or the salt. So if that clarification hasn't come, then you may get very high. Yeah, so I think maybe in stating the protocol, you may have to clarify that or make that obvious. That it should be based either, it needs to be stated, whether it's base or the salt. Then we can be fine. Thank you.
Hello. Yeah, so we want more pharmacists to be in the manufacture, to be able to prepare, get the caffeine salt. It's very easy, right? So that you prepare. And then I think our hospital, the language is the salt. We never talk of the base so that we don't get confusion. So any prescription we write is about the salt and nothing else, right? So we want more hospitals to be able to prepare the caffeine. And then, or if it's already, if you procure it, we know that we all talk in terms of the salt. I agree. Yes.
Hello.
Thank you, Dr. Agiman. I really enjoyed your presentation, but what I want to know, and it's also the same issue I'm also having in my country, what do you think is causing the variation in loading doses? I know from your study, majority use 20 milligram per kg, but there's still that variation everywhere. It's not just Ghana.
Sure.
What do you think is causing that variation? Shouldn't there be like a standard dosage like with every other drug when we're talking about loading dose? Like, why are doctors giving caffeine citrate in variable doses? I know you also mentioned that caffeine citrate is bespoke for babies, but you said that in terms of stopping, not in terms of dosage. So what's causing it? How can we get a unified dosage? Thank you.
But I think Prof will bear me out that I think even in advanced countries, they also went through this phase of having a lot of variations until the CAP trial came. And then that CAP trial in 2006 really answered that question about the safety of caffeine within that dose, right?
If I can just add a comment, very good question. With regard to the loading dose, it should be that easy, 20 milligrams per kilo per day. But in the CAP trial, they varied the daily dose, the maintenance dose, between 2.5 and 5 milligrams per kilo. So 5 to 10 milligrams per kilo per day caffeine citrate. And because of this variability, clinicians are left with the choice, should I use the lower range or the upper range? That's why I mentioned this secondary analysis, which clearly showed an effect on the primary outcome was only visible in infants receiving more than 7 milligrams per kilo per day. So, and we rounded up to 10. Because here I'm really convinced giving a bit more will help more. You should not give more because of this risk of bleeding, but up to 10 milligrams per kilo per day maintenance, it's absolutely safe. And I think this requires guidelines, national guidelines, and I'm sure, given that there's a caffeine association now on this continent, we will have some in the future.
Is it?
Are you working on the guidelines? Are there any guidelines planned for how to treat children with AOP?
Yes, so I think for now it's a hospital. It depends on the hospital.
Hospital.
We seem not to have So I think it's the next phase that we really need to really look up to this. Yeah, because remember, this is a country where 50% of regional and tertiary hospitals are still using aminophylline. So you see where we are. So the first is to make sure that we say caffeine works. We all should move to caffeine. It's very safe, good therapeutic window in terms of cost, in terms of half-life, and then the next is to probably get the guidelines on.
But I mean, my experience from Europe, mind you, we don't have caffeine available for such a long time. So it was only licensed for use in preterm babies in 2008, so 15 years ago. And really the use of theophylline had really dropped from 50% to less than 5% now, within just a few years, because of the availability. If you have a suitable product commercially available, you're much more willing to drop your previous behavior compared to if you don't have an alternative available. And that, thanks to your launch here, is now possible.
Any more questions?
Yes, Prof.
For Dr. Ajiman, do you, ever send babies home on oral caffeine? And Prof can also comment. And then in your units, you have apnea monitors, or how do you, or you just use a clinical, features to decide apnea-free days? Thank you.
Hello.
Right. Yeah, I can see you on the ground. Right. So we don't have apnea monitors, and I don't think it's not really disturbing. All our critically ill babies, we have continuous monitoring that picks them up. Right. And then we are trying as much as possible I'm trying to convince not to discharge babies home on caffeine. We want to stop caffeine before we discharge. And we realize that at 10 milligram per kilo, that maintained dose, quite a number of our babies struggle with weight gain. Probably because of increased metabolism, right? So if you are apnea-free for 3-4 days, we will stop and monitor for 3 more days, and you are home. So currently, we want to stop the practice of sending babies home on caffeine.
Just a word of, add a comment. Apnea monitors are useless. You need pulse oximeters because it's the hypoxia that matters. The hypoxia may be due to apnea, but there may be other reasons.
Yeah.
And obviously, we do send some babies home on caffeine plus a pulse oximeter then, but that's in a setting where monitors are much more widely available. But whether that's a good thing or not, we don't know. So if you don't do it, I think that's a good decision. It's never been tested, to be honest.
Yeah. Yes.
Yes. Good.
Yeah, so we answered that question. Go ahead.
Well, as soon as the baby tolerates oral feeding, we give it orally.
Yes.
You should not have an IV access just to give caffeine. Never, ever.
No.
Too high risk of infection.
Yes. And, we struggle with IV lines here. Our plasters are not good. And the tiny babies in my unit, on average, they may get IV puncture like once or twice a day. And if you can avoid it, it's the best.
Yeah, she should avoid IV whenever possible.
Absolutely.
And that's independent of whether it's Africa or Europe. It's never good.
Yes.
Also a good question. I don't think there is an antidote. The beauty is it's so rare. There are 3 case reports of accidental intoxication, but they were not severe. They washed out also after a week or two. But there's no antidote. That's the bottom line.
Thank you very much. So I want to find out, Dr. Ajiman, you said usually when children, preterms are put on caffeine and you monitor for about 3 days, and that is without apnea, you discharge the patient, you observe for another 3 days, and then apnea-free, they are good to go home. Is that it? Good. So in an instance where usually mothers are educated what to look out for when they go home. So in the situation where the mother or whoever is with the baby notices that, yes, at home, that the baby is having apneic attacks, if the baby is brought back to the hospital, do we put the child, or are we supposed to put the child on caffeine again?
You don't just put the baby on caffeine and leave the baby. You go back to caffeine and screen for infection. And other way. So provided the baby is still less than 37 completed weeks, you always go back to caffeine and then investigate the possible. Remember, apnea, yes, it's from the brainstem, but a lot of things will potentiate it, right? So a well-looking apnea-free baby who all of a sudden starts developing apnea, search for secondary causes. That is the message. So that baby will go back to caffeine, but we aggressively search for what caused that. Question? Yes.
To her question, and it was usually here following up. Already the clinic is burdened if you even have a preterm clinic, and sending the baby home without the caffeine. Sometimes our mothers are very loving but very late to pick up things. Is it not safer just to wait than to wait for the baby to have another apneic episode and then restart with what? The loading or the maintenance? Why not just wait till 37?
Yeah, if the baby in question has crossed the 33, 34 weeks and it's apnea free for 3 days, you've stopped it. Remember, babies do well at home. And we don't want to keep them for too long. And this question about when preemies go home. Prof, when do you go home in Germany?
It is important. It's a daily question we are always faced with. And as I told you, we require 4 days without intervention. So I give a lot of responsibility to the hands of our nurses. But they know what they are doing. They know these babies. So if they think this baby is having such a severe spasm that we need to intervene, then we wait another 4 days. That may be luxury, but that's how we do it. But compared to what the States do, they require at least 5 days. The French, 7 days. It's funny how it varies from country to country. No, because nobody knows what the true answer is.
Any baby that's been very well and starts getting this reflux is something that we see a lot. So mommy's skill at feeding is so important. So I think that factor, making sure that the caregiver can adequately feed very well before going home, is so crucial. Otherwise, you keep these babies in hospital for too long and late sepsis sets in.
Thanks. Now the discussion becomes more lively. Basically, I would warn against over-interpreting reflux. They all spit up occasionally. And it has, we looked into this very closely. We did a study on this many years ago. There's no temporal relationship between gastroesophageal reflux and apnea. There may be the occasional exception to that rule, but as a rule, and that's why you don't need to treat the reflux if you have a baby with apnea. That's what the Americans still are obsessed with, but that's not evidence-based, to be honest. So you should not treat reflux in a baby with apnea.
I may disagree a little bit. We don't treat this reflux pharmacologically. I mean, our first step is to use positional therapy, and we benefit from that a lot. I mean, mother finish feeding and going to the KP position is brilliant.
I was talking about drug-free.
Absolutely. No drug. Yes, go ahead.
Thank you very much. So I'm just trying to still, you know.
That makes it a caffeine, discussion. We can never get answers.
Okay, so
Yes.
I think we need to be able to get to the point where, what we've been discussing all the while is about how soon we can stop caffeine. I mean, it's part of the discussion.
Sure.
How soon? So, like the other lady suggested, maybe so that babies can be safe. Sometimes you will observe the baby is really having no issues of apnea.
Sure.
Has been apnea free for about 3 or so days.
Sure.
Is it not safer for the baby to go home with caffeine, so that you want to be watching your back
Yeah, but
at every given time, so that they don't have to come back after all that they have been through, and then you have to more or less repeat all that happened. The issue is like there's a take-home thing I want to have,
I
so that we all
perfectly
work on the same
I
line.
agree with you, but remember, caffeine that way is also a drug, and I've never seen how you keep saying I've never seen a drug without side effect. All our discussion, we trying as much as possible to get the best out of the caffeine, while we are minimizing toxicity as much as possible, right? So again, it's just like transfusion. I don't think one option will fit all. If you have a previously 27-weeker whose corrected age around 34 has had a very turbulent neonatal period, repeated apneas in the past, right? And we are 34. Of course, even if we've been apnea-free for 3 days, I will not quickly stop it. If I compare that same baby to another 28-weeker who's had a very free neonatal ride in my NICU, never had any apnea, in this thriving, probably I may discontinue that at 34 weeks. So I still insist that it's individualized, and then we take it from there. Right? Yes.
There's a question online.
Yes. Prof, repeat it. Repeat it for us.
You can. The question about IV caffeine. You should give it orally as soon as the baby tolerates any oral feed. It is absorbed. 100% of what you're giving is also absorbed enterally, so you don't need to change the dose between IV and orally. And it is not with any gastric side effects, so it's safe to give it orally as soon as you have. I mean, our nurses are starting on day 2 with oral caffeine. That's possible. And as we both agreed on, it's much safer to give to get rid of an IV line than to maintain the IV line just to give drugs. If the baby needs it for fluid, no question, or for antibiotics, but not for caffeine, please.
We do get a lot of very sick, preemie babies. Right from day 1, baby's abdomen is distended. We have coffee ground, vomiters. They are the candidates we may initially go for IV, but not sure.
So, we want to. You have a question? This is the last but one question. So,
okay,
if anybody has a question,
mine is a comment. I was just saying that, with all the varying views and, on what to do, what not to do, it just points to the fact that we need a lot more studies from our own local data. Dr. Ajiman, I think you have a lot of data, a lot of babies you've seen over the years. I think if we are able to put these together from different centers, we can have a lot more answers related to our setting. And I think that will really help address some of these questions. Thank you.
the last question, then we move on to the next segment.
Okay, that was a great presentation. I would just like to know the best storage practices when it comes to caffeine, because I've personally witnessed people storing caffeine in fridge. I've also witnessed some facilities also just storing in room air. So what's the appropriate way to go by it?
So the temperature shouldn't be above 25 degrees. So you can store it in the normal room temperature. So I mean our brand. I'm being specific. Our brand, it shouldn't be stored, because I don't know how the extemporaneous preparations are done, so I can't comment on that. But for ours, the temperature shouldn't be above 25 degrees Celsius.
So where is the pharmacist? Can you help us with that?
Yeah, thank you. Well, from experience and I work at Trust Hospital. So what we advise is keep it in the fridge. I'm sure, especially in this weather, if you take room temperatures, your best bet, they are more than 25. So your best advice, especially those prepared from wherever, just keep it in the fridge. And we normally don't use any preservatives. So you use for 7 days, you come for a refill. Safe. Otherwise, you end up giving your baby some, thank you.
Just to give more context to your question, like vaccines, you have to store between 2 to 8. So when they are keeping it in the fridge, what temperature are they looking at? What are they aiming for?
Well, what's the fridge temperatures? No, vaccine fridges, they are different. Ours is the regular fridge, no vaccine fridges. Thanks. Yes, kind of below 25, between 10, 15, 25. Thanks.
And if you bring it out of the fridge, you should warm it to room temperature before giving it to the baby. Absolutely. Yes.
It's getting more interesting, but we have to move on to the next stage. We have to move on to the next item on the bill. Okay. So I want to thank Prof. and Doc. It's been very, very, very insightful. I've really, really learned new things. Thank you very much. So the next item on the bill is we're going to launch our caffeine citrate. We're going to introduce it to the audience. So I would like to invite Dr. Barbara. Down.
One, two, one, two, one, two.
So we are going to watch a video. We are going to follow the screen and do the countdown together. Are we ready?
Ladies and gentlemen, may I have your Gentlemen, may I have your attention, please? Starts in 10, 9, 8, 7, 6, 5,
I present to you Caffeine Citrate from EAF Farms. Hello. This Caffeine Citrate, IV and oral from EAF Farms. Thank you. Thank you very much. Thank you. You may take your seat. So we are almost done. The next item is we want to talk about the availability of caffeine citrate in Ghana, because we are talking about caffeine, but we need to show where you can get caffeine. It's very important. So can we move on? Okay, so without waiting for the slides, okay. Okay, I'll go on anyway. So caffeine in Ghana, caffeine, EAF Farms caffeine, is distributed by Gokal's Laborex Limited. Gokal's Laborex Limited is one of the biggest distributors in the country. They distribute nationwide. So I'm sure every hospital in Ghana knows Gokal's Laborex. So if you talk to your procurement people, they know Gokal's Laborex and they distribute across the country. So I also say that in the southern Ghana, Gokal's Laborex is located in Accra. They have sub-distributors across the country. So they divided the country into 3. So in Ashanti region, they have a sub-distributor there. And in the north, they have another sub-distributor there. So in the north, we talk about Gina Pharma, which if you are in Tamale, they have pharmacies just across the street of the Tamale Teaching Hospital. If you go to Bolga, Gina Pharma is also available close to the regional hospital. Gina Pharma has other branches, so they have about 6 branches in the north. So those from the north, you're going to get it. So if anybody wants to get it, you don't really have to come to Gokal's. If you're in the north, you can do that. Now, in Accra, you can, Accra, Volta, Eastern, Western, you can contact Gokal's Laborex directly in their office. I'm sure your procurement guys know them, so you're going to get the product available. I was going to also talk about the dosage of us. So our recommended dosage. Can the slide change? So this is how our caffeine citrate looks. It's both oral and IV. Now we have the other one on the right side. That's oral, but it's not yet in Ghana. It's the SKU of the product, but it's not yet in Ghana. But fortunately for us, we have both oral and IV in the other pack. So that's what is available in the country, and if you want it, you go to Gokal's Laborex, you're going to have it. So I'm going to briefly go through our recommended dosage. Then I think my job here should be done. Okay, so now as the facilitator said, so the dose of caffeine citrate is twice as the caffeine base. So if you have 10 milligram, the base is 5 milligram. Now, this product is optional. You either choose oral or IV based on the situation, based on the patient you are dealing with. There's no dose adjustment between the two. So either you go oral or you go IV. You don't adjust the dose. Now, the second loading dose can also be administered when the first loading dose fails, within 4 hours. Normally, it starts working after 4 hours. So if it fails after 4 hours, we expect you to have another loading dose. But if the second loading dose fails, we also would advise that you check the levels of the caffeine before you give a third loading dose. So let's go to the dosage. So the first column says caffeine citrate solution for injection. So we're talking about the injection. The loading dose is 2 ml per kg. Remember, our pack is 1 ml ampoules times 10. So we give 2 ml per kg, that's the loading dose. So in caffeine citrate terms, it's going to be 20 milligram per kg. The caffeine base is going to be 10 milligram. As I said, caffeine citrate is, twice as the base. So in IV, you administer it over 30 minutes, and the frequency is once. That's the loading dose. We go to the maintenance dose, which is 0.5 to 1 ml. As Prof said, the higher the dose, the better. So he was saying those who are doing 7 milligrams were doing better. So we expect 0.5 to 1 ml. In the caffeine citrate equivalence, 5 to 10 milligrams. So automatically, from Prof's recommendation, we are recommending 10 milligram, which is 1 ml. Okay. Then the caffeine base is 2.5 to 5. So the maintenance dose is done in 10 minutes. And this is done every 24 hours. I guess it's simple, and I think this recommended dose has a lot of research backing it, and we believe if you apply this, your neonates are going to do very well. So, I would like to thank you. I would like to thank you for coming. And, okay, you have a question. Okay. Do you have a mic?
Hello, thank you very much. Regarding to the administration of the medication you just mentioned, let's say you said we should give the IV over 30 minutes, and let's say my baby comes and the weight is, let's say 1.5, and we are giving the loading dose. If you're going to give, let's say 20 milligram, that's the 1 meal, 2 meals, over 30 minutes, are we to dilute it and use a perfuser, or we are just to go bolus but slowly for over 30 minutes? Same goes with the oral. Thank you.
So you are not going to dilute it, you are going to give it slowly to the patient. I also like Prof or Doc to comment on that.
Yes, we also give it slowly IV, we don't use it with a perfuser.
Any more questions on the dosage? Okay. Okay. So,
I want to know the prices for the injection and the syrup.
Okay, so the caffeine, what we have here is just the IV, the ampoules, so we don't have the oral one. So the price per ampoule ranges around 100 cedis. It ranges around 100 cedis, depending on the facility you are in. Each facility has their own way of putting margins on products they get on wholesale. Yes, the question is, do we have plans on putting it on NHIS? We want to start that discussion. We know that caffeine is on the WHO essential list, so we'll make that argument. And because from where we are, the limiting factor would be price, and we don't want price to limit, the patient. And one thing I've also observed is that, not in a funny way, but most of the neonates we have are from less privileged backgrounds. So you go to the north and you see, Prof, I don't know if I'm right, but most of the girls in the north are married off early, so their propensity of having, premature infants are high. So I know that the numbers are very high in the north. Notwithstanding, we also have our numbers down here. It's not scientific.
Of just one of the, risk factors. Of course, we do not have, in our neonatal units, we do have adolescent mothers, and I think that cuts across even the whole country. Of course, we already have, disparities in terms of income between maybe the northern and then the southern part. That may be a general risk factor that can contribute. Of course, we would always be happy to have a price that the generality of our patients should be able to afford. And that is why we are, talking about NHIS and whether we can put it on NHIS. That would really be, very supportive also. Thanks.
So my answer to that is we want to start those engagements with the NHIS. We are also working with some NGOs. I don't know if you know CHI, Clinton Health Initiative. We are working with them, in other countries. We are hoping that they will get to Ghana. And when they get to Ghana, we will be lucky to get the product on an access, program, or it will be subsidized. So we are working all avenues to make sure that the price comes down. Any other question?
Can the drug be stored in the fridge? Is the vial, if there's some remaining, is it reusable, or you use once and then discard?
So you use, and if you didn't use all, please discard. Don't reuse. It's a 1 ml ampule. It's 1 ml ampule. So if you use 1 ml ampule, what will be left? So kindly discard, Any other question? Yes. You have to discard immediately after use. So I have the Gokal's sales manager here. I want him to tell us their sub-distributors across the country. So, Mr. Charles Eshen.
Well, good evening, I'm Charles. We have 3 sub-distributors across Ghana. Like he stated earlier, we have TBS Pharma, who sits in Kumasi. So they take care of BA and Ashanti. Then we have Jina Pharma, who sits up north and takes care of all the, how many regions in the north now? 5? All the, northern regions. Then we have Capmore, who is in central western. Yes. Then when it comes to Accra, Eastern, Volta, we take care of ourselves. Yes. So that's about it. Almost all the main or bigger distributors in Accra, they buy from us. So when you go there, you can get the products. All right.
Thank you, Mr. Charles Eshen. Okay, so we've also tried as much as possible to make sure that those in major facilities, so regional hospitals, teaching hospitals, even if it's not available in your facility, it's in the pharmacy opposite your hospital. So the pharmacies close by, they are there. There are chain pharmacies like Top Up, like Answer Pharma. We are trying to get it to NS Chemist and East Cantonment. They have bigger chains, so we are trying to make sure it's available nationwide. So it will be available wherever you need it.
so much. About the price, I know it is a price you have gone through a lot of consultation to finally achieve that. But seriously, a typical NICU baby who spends just about 7 days in my institution will leave paying over 4,000. Okay? And that is without this caffeine citrate, which is 100 cedis for a meal. So I don't know, especially for those who are less privileged. And of course, in fact, in Ghana, now it's not just about being less privileged. The economy is hard. It's a very tough economy we have now. So is there any plan that that is being worked on so that at least those who truly can't afford it, but then we know they need it, those people, is there anything that we can work around and then have those people, to benefit from the medication?
So a follow-up on that. So I'm Samuel from Trust Hospital. So you mentioned that your pricing, there's this difference in the northern part and then southern, right?
It's me, dependence of the facilities.
No,
I didn't say that.
You made mention of something price difference.
I was saying that each facility have their margins. Some have 20%, some have 10%, some have 25%. So typically, private facilities put in more margins than the government facilities. I know the government facilities do averagely 20 to 25%, but the private facilities actually go higher. So it depends on the margins they put on the product.
So how much will a NICU baby in Upper East Region buy it for?
It depends on the facility. It depends on the retail. If it's in a retail outlet, I know that the retails do average 30 to 35 or 40% markup. But we are also telling the retailers that this is a life-saving product, so they should be considerate when putting their margin. So anybody that's or the chains that I contact, that's what I tell them, that they should be considerate on the margin so that the majority of the populace can afford.
There should really be checks, or else someone might just die just because being unable to purchase it.
But Doc, my question is, they have brought IV caffeine. The drug works. So we, the clinicians, it's up to us to probably speak to government or whoever it is to make sure that we get it. But what do you want him to do again? I agree with you. Yeah. Yeah.
Because this is a life-saving drug, for immediate treatment, do we have to engage the government for how long?
So what do you want him to do?
I mean, empathy. He should try. I mean, the company. I don't know if the company is here or something.
Okay. But we'll try. We are in several discussions.
Let me say this. I've worked in the Upper East Region for 15 years, okay, and I've managed NICU babies for almost 10 years. And I tell you, I don't know if someone can really compare. It is very rampant there. Premature, babies that really need caffeine citrate is very much. You can have about in a day 10 to 15. It's become like we are trying to.
You see, it is not about. It's perfectly it's understandable. I get it. Some of us manufacture different things, and I know that it comes to give a price, to price your item, you would have sat down. You think about what goes into production, the cost involved, the workers you need to pay, tax elements and all that. All these things come to play for you to, price your item. Understandable. But the truth is that, I again come back to, there are people who really need it, and then it's expensive. That's the borderline. For I'm sorry, but I feel for a while. I also understand that a lot goes into production. But then those who can't afford, there are even people that we have to be paying, help them pay their bills. All of us, I know as health workers, one way or the other, we might have helped someone pay his or her bill. Some facilities will just wipe it off as though it never happened. But then what can we do? Like, are we doing something for those who can't really afford the medication but really need it? Since
we very much appreciate all this comment about the price, and we knew it that they are coming. And we are fully aware about the price of the product, and as I told you, that's my also personal thing. So what we are doing, there are different ways how we are trying to approach the price. So of course we will ask you for help to talk with the government or with the officials who could help us to put on the lists which it should be. The second way is we are working with CHAI. Next week is a meeting, and I think Ghanaian representative is also there. We are working with them on lowering the price for the region. So I cannot promise you now that it's going to be this or that price, but we are fully aware, and believe me, you have full of our empathy. I went to this many NICUs, and we know that it's what needs to happen. And this is my role and my mission to talk to the guys in France or in UK where our bosses are, and to convince them that we need to do something and maybe look for the profits somewhere else. So there was another one, which we are working with our distributors.
So I think our distributor wants to say something.
So on our side, we know how expensive the drug is and all. So we have tried to introduce other incentives in terms of purchases, so, i.e. introducing discounts and all that. So that's how far we can go. We are also trying to see if we can also reduce our margins just for the patient to benefit. So these are our conversations we are having with them. I mean, Ray and other people to see how. So I'm sure maybe in the next week or so, the prices that he probably is quoting may go down just to satisfy the patients. Yeah, right.
Thank you. Thank you. I guess you see, opening so our distributor who is going to sell says the price is going to come down. It means it's going to come down. But we've made the proposal, so I'm sure we'll conclude soon and it will reflect in the market prices. So thank you very much. I want to give some few remarks, then we can close and go for dinner. The dinner is here, so you'll be ushered table to table to start the dinner. So in concluding, we want to say thank you for coming, and you being here shows your commitment to supporting neonatal care in this country. We thank you. EAF Farms is new in this country, and we are glad that you have received us very well, and we know that going into the future, there are more great things to come. EAF Farms is not here just to sell. We are here to support the neonatal space. So we'll be visiting less endowed facilities, and we'll try as much as possible to support in machinery, in equipment. However we can support, we'll do that. So we want to assure you that we'll be with you in the end, and we thank you for coming. Thank you. Then finally, we want to have a goodwill message from PSG. You know, we are partnering with them on the World Prematurity Day celebration. So I would invite Dr. Claudia Ajasai to give us a brief goodwill message from PSG.
Thank you very much, Ray. Good evening, everybody. I want to thank EAF Farms for the invitation, and thank you to all our speakers. I believe it's been very enlightening and it's generated a lot of discussion for us to take after here. I want to also acknowledge the national president, Dr. Hilda Mantibiaboy, who's given me this opportunity to give this speech on behalf of the national executives. So the Pediatric Society of Ghana would like to extend its warmest congratulations to you, EAF Farms, on your successful launch of the IV caffeine citrate today. This launch has shown your commitment to advancing healthcare for children, especially the neonates, and more so to speak for the premature babies, and your commitment to improving their quality of life. We say that we can see you are dedicated towards raising awareness about prematurity and providing effective solutions like with IV caffeine citrate for the same in truly is really remarkable. We are also grateful for your support towards our Prematurity Awareness Month advocacy efforts, and we hope this support is just the beginning for many more to come. So once again, we say congratulations on your successful launch, and we wish you the very best moving forward. Thank you very much.
Thank you. Thank you. So then the next thing we want to do is, I did a nice backdrop at the back there. Please don't let my decoration go to waste. So I would expect you to take pictures. So I'm going to mention some few hospitals, notable hospitals, and if you are staff from there, you can join us and join our resource persons, and we're going to take some few pictures. At the same time, the food is ready, and the ushers are going to usher you to start. It's a buffet, and please enjoy yourself and have a nice time. So I'll start with our good friends from Ridge Hospital. So Dr. Ajimai and Prof, Dr. Barbara, can you join us?